Good afternoon and welcome to our virtual live weight loss surgery seminar. My name is Jesse Gutnick. I'm one of the bariatric surgeons. We've got a great panel today. I'm joined by Bernadette Brown, who is both a weight loss surgery patient and works with us in our department, as we're in Karen Schulz, who is one of the APRNs in our department within obesity medicine. And so they'll be talking about their respective roles. And Bernadette in particular is going to be giving her personal story, which is quite amazing. Um, just to give everybody a brief overview, we'll plan on this lasting up to an hour. Um, we're going to hear about Bernadette's story to start off with. I'm going to talk a little bit about how weight loss surgery works and the safety of it. Um, Karen Schultz is going to speak about what to expect within our program, and then we'll get into a Q&A. To send in questions for the Q&A, please submit them to the chat to all panelists so we can see them. You can submit them at any time during the presentation, and it's great if you can do them early, actually. And then at the end, I'll be moderating the Q&A session based on the questions you submitted. And with that, I'm going to pass things off to Bernadette.
Hello, all. So, just some background for me. I was a smaller baby than most people. I was born a month early, so I came in 4 pounds, 14 ounces. That was the only time in my life I was smaller than other people. I spent that first month of my life getting medications and things to catch up. Came home in a baby doll's clothes because they didn't have preemie clothes back then. And I quickly surpassed everybody else. I was bigger than the other babies, bigger than the other toddlers, bigger than everybody in my classroom. Um, by 12, I'm 5'5", but I was 180. I mean, bigger than the other girls. 14, I was over 200 already. Um, Fast forward, late teens, early 20s, I had um, 2 kids. I got married. My little girl passed away, and in your early 20s, you don't know how to deal with that. Nobody knows how to deal with that. But not having a good handle on life at that point, I ate and I ate and I got up to at least 304 pounds. When I got there, I wouldn't get on the scale anymore. So I'm actually pretty sure that I got higher than that, but um, I wouldn't get on the scale. So that's my story. Um, so I realized that I needed to do something. I tried everything, every infomercial that I saw, every book I saw. I mean, everything. I don't know if you guys remember the whole Atkins So, when was enough enough? Um, I'm a daddy's girl to my core. I mean, a daddy's girl. Like, he was my sun and my moon. And in 2011, my dad was diagnosed with end stage heart failure. This was the strongest person I knew on earth. I mean, he didn't have many health issues that I knew of. He wasn't
There's a whole bunch of other hormones. You might notice this one down here in the bottom left, GLP-1. That's the hormone that the newest weight loss medications that you hear about in the news um, work on. But weight loss surgery works on a whole bunch of other ones, including ghrelin, protein YY, bile acids, and more. So the most commonly performed weight loss operations in the United States are the sleeve gastrectomy and the gastric bypass. And I'm going to focus the scientific papers that I'm going to review with you on those, but we also perform some of the less common ones, including duodenal switch, SADie procedure, and revisional or corrective surgeries for people that have had weight loss surgery in the past and need some extra help from those. Let me go over those first two, though, because these are about 90% of the operations that are performed in the United States. On the left-hand side of your screen is the gastric bypass. That's really a stomach bypass. We make a very small stomach out of the top of your stomach, bypass the rest of it by directly connecting it to the small intestine. The sleeve gastrectomy, we remove about 3/4 of the stomach's volume and take it from about the size of a small purse down to approximately the size of a banana. And it almost, you can see on the picture on the right-hand side, it almost looks like a sleeve with a seam down one end, like a long sleeve shirt would look like. Let me talk a little bit about the research articles that have studied these. The first is a really important landmark paper. We particularly like it because it was performed here, but this is a paper that really changed the landscape of how people thought about weight loss surgery, because it didn't just look at people losing weight, but it was a randomized controlled trial, which is the best method at comparing treatments, looking at people that had diabetes and obesity. And the first thing to notice, this is a graph showing the decrease in the BMI, or the body mass index, which is how we measure your weight by height ratio. And when compared to people that got the best medical treatment for their diabetes, and that's in the yellow line, and you can see that they did have a decrease in their BMI of about 2 points compared to gastric bypass and compared to the gastric sleeve. And this is following people up for 5 years. And you can see a significant and sustained decrease in the BMI over that time. What was really important about this study was not only did it show a really sustained improvement in the weight loss, but it also showed a really sustained improvement in the hemoglobin A1C, which, if you're diabetic, if you have a family member who's diabetic, is a really important measure of your sugar control. And with both gastric bypass and gastric sleeve, and this is compared to the best medical treatments. Best medical treatment had, at best, a change in 2 points of their A1C, and for these, there was around 3 points, and it was much more sustained over time. You can see the yellow one goes up much more quickly. So similar to diabetes, weight loss surgery treats all of the ailments that go with obesity. Most common ones: sleep apnea, osteoarthritis, certain heart problems, high blood pressure, etc. Ideally, if weight loss surgery is performed relatively early, they can be prevented. But even if you already have them, they can be stabilized or reversed. So with that in mind, and that's sort of, one aspect, like what are you trying to achieve and how does that work? Well, what else do we have to think about when we're thinking about weight loss surgery? And I think that's really the safety of the intervention or that treatment. The way I like to think about safety is not just thinking about the operation itself, but comparing weight loss surgery to the usual care. So what would happen if I didn't have weight loss surgery, or what would likely happen? And really, there's a small upfront risk of surgery. It's not a large risk, but it does exist, and it's an upfront risk. And there's a really large health benefit over time. And we already talked a little bit about those health benefits, but we'll look at them in another way. So in terms of that upfront risk, obesity surgery has been around since really the 1970s. And it used to be relatively risky, but there was a revolution in the late 1990s and early 2000s, where the risk of death from weight loss surgery started off at around 4 in 1,000 at the year 2000, and then over the next 10 years went down tenfold. And actually, since then, it's gone down another tenfold. to today, depending on the study that you look at, but all very large studies, it's approximately 0.8% risk, or less than 1 in 1,000. Now, how does this compare to other commonly performed operations? This is a comparison that was done, again, in diabetic patients, because patients with diabetes are more likely to get complications from surgery. And so this was a good group of people to look at this in, because it would expose the worst of it, or however you want to think about it like that, sort of would show the people that are most likely to get a problem. So if the top line is the risk of a complication with a heart bypass or a CABG you may have heard of. That's almost 50%. Colon surgery, around 12% risk of complications around the time of surgery. And then other ones like a hysterectomy, gastric bypass, or gallbladder surgery, all very, very similar, around 3.4% chance of getting any kind of problem, not just major complications, but even a minor problem. And so that's quite low. Now, the other thing is comparing another way of looking at things, not just looking at diabetes, but looking at other health issues over time, and how weight loss surgery can affect or decrease that risk. So this looked at people with heart problems, and it was a subgroup of people that had diabetes, because people with diabetes are more likely to have heart problems, and so we'd expect that to be a bigger improvement in that group of people, because they're more likely to have a bigger problem. And you can look at this graph on the left-hand side. So the patients who did not have weight loss surgery had this sort of control rate, or this set rate of problems of cardiovascular problems like heart failure, coronary artery disease, arrhythmias, stroke, kidney problems, and then compared it to people who had weight loss surgery. And you can see that much lower line. So it still goes up, because they're still living, over time, and they're still at a higher risk than maybe another person with a similar weight because of their diabetes, but it's significantly decreased over these 8 years. So to break it down, with weight loss surgery, people get longer life by treating sleep apnea, diabetes, improving the safety of childbearing, improving the quality of life, for example, with joint pain, so you can be more active. There's an emerging, and not even emerging, now pretty well established, decreased risk of certain cancers that can be provoked by obesity, treating fatty liver, and many, many more other health issues. And with that, I'm going to turn things over to Karen Schulz to talk about some specifics about our program.
Okay. Thank you very much, Dr. Gutnick. Hello, everybody, and thanks so much for being here with us this afternoon, taking the first step to learn more about bariatric surgery. In addition to being an advanced practice nurse, taking care of patients in our program, I'm also the coordinator. We do bariatric surgery in 4 sites here in the Cleveland area. So no matter which place you have surgery, we work very hard to have the same high quality experience. Let's talk a little bit about the program and how you can become a patient. We provide a lot of the care now virtually, so as close to home or in your home, making it as convenient as we can. We always like to see you, so we have lots of satellite offices. We do surgery at main campus, and we have a clinic there. To the west, we do our surgeries at Fairview Hospital. We have a clinic in Avon, also a brand new clinic in Westlake for those West Siders. And then out east, we do surgery at Hillcrest. We have an outpatient center in Twinsburg, and also Mentor, and working on very soon to do surgery in Mentor as well. Next slide. Yeah, so thanks for choosing the Cleveland Clinic. Lots of great things. Number 2 hospital in the country, main campus where the Digestive Institute is, where we are. Bariatric surgery is number 1 in Ohio, number 2 nationally. Fairview's high, Hillcrest is high. We don't take your trust for granted, though. Really appreciate you thinking about the program. It's a very supportive program with lots of resources at the Cleveland Clinic. Next slide. One of my favorite things about the program is that each patient, actually each surgeon and patient, has a navigator. So we know that sometimes the journey to surgery can be a little bit complicated, and you have a person that's dedicated, first of all, to checking your insurance, to making sure you have coverage for bariatric surgery, and then answering any questions along the way, should you have them. You miss an appointment, you get lost in the program, you have someone to reach out to. And then the patient navigator is going to ensure that, first of all, you complete all the insurance requirements, and then they will submit that information to your insurance company before we schedule surgery, so you don't have any of those financial concerns ahead of time. And then after the navigator, once you're approved for surgery, you're handed off to your very own care coordinator, who is an RN, like Bernadette. She's one of our care coordinators, and they will make sure that you are completely ready and educated throughout that perioperative or around the time of surgery time period. Next slide. In addition to the navigator and the care coordinators, you are surrounded by a team of specialists. Okay, so there are 4 main visits in the bariatric surgery program. You will see a dietitian at least twice. Okay, and that person's going to do a full assessment on your eating habits and make sure that you know exactly how you're going to be eating around the time of surgery and out into the rest of your life. You have an obesity medicine provider. I am one of those providers. We have about 4 obesity medicine physicians and 7 nurse practitioners that are designed to helping work with your primary care physician, if you have them, to make sure that any health problems you have are, first of all, detected and in the best control possible upon getting to surgery. It's one of the ways we make bariatric surgery the safest general surgical procedure in America is by our great surgeons, obviously, and then that medical screening to make sure health problems are in good shape. Now, having said that, I want to assure you that we get some pretty, patients with pretty serious health issues through our surgeries safely. So people with diabetes, with sleep apnea, those are just the standard patients that come to our program. And people who may even need organ transplant. So we're used to the full array of health issues, and we still get patients safely through these operations. Everyone will see a bariatric psychologist, even if you've never seen a psychologist a day in your life. That person is going to help you be emotionally and psychologically ready for surgery. We understand that people eat for lots of reasons other than just to feel full. And it's important that you have those tools in place to be able to do well from an emotional and psychological standpoint. If you currently have a mental health care provider as part of your team, we'll work with that individual to make sure that everybody is together and making sure that whenever you choose is the right time for you to proceed. And then you'll also see the bariatric surgeon once before insurance approval, and then once approximately a week before the surgery. In addition, we use a lot of consultants if you need them at the clinic. Sleep medicine, endocrinology, cardiology, pulmonology, it's all available there if you need it. Next slide. All right, and now we're to our question and answer time period. I'm going to ask the panelists to come back online. And if you have any questions, now's the time to put them in the chat. I think we have one so far. Oh,
yeah.
Next.
So please, everyone, keep on submitting questions. I'll start with the one, and I'll also ask some common questions. So Karen, the first one is, this person is interested in an orthopedic or actually a spine procedure, and their spine doctor has given them a weight loss goal so that they can do that operation with the best possible outcome. Maybe touch on both how frequently you see patients with the same issue motivating them, and the types of outcomes they can expect to have?
Sure. Yes, we see a lot of orthopedic patients. So spine, back surgery, knee surgery, people that need hip replacements. It's very common now that doctors will refer their patients to us prior to bariatric surgery, prior to the orthopedic surgery, because they know how much better you're going to do with that joint replacement, with your spine surgery, if you lose weight and if you lose weight permanently. So, going on a diet is sometimes possible as well, but if you regain the weight after the orthopedic surgery, knows how hard that's going to be on that joint. So it really is a preferred method for a lot of our orthopedic doctors. People come to us first, get through the program depending on insurance requirements, and then I know at least 6 months in. I don't know what your experience is, Dr. Gutnick, but usually it takes 6 months to lose enough weight that the orthopedic surgery can then be done safely. But we see it all the time, and it really does help.
Yeah, I mean, the other nice benefit is not every time, but not infrequently either. Often people are able to put off their weight loss, or sorry, put off their orthopedic surgery once they've lost weight. They may not have zero pain if it was severe before, but they have enough of a relief that they're able to put off that joint surgery or joint replacement for several years, if not longer, which is super helpful because those operations do have a lifespan before they may wear out or need to be redone or something like that. So it's nice to be able to put them off for as long as possible or get the best outcome. Generally, the orthopedic surgeons will give a target BMI and people can get it anytime after that. But I ask people to try to get to their final weight loss to see if they even need it. And because they'll have an even better outcome at that point too. So now, Bernadette, I'm going to skip a couple of these and I'll get back to answering some of them. Really common question, which we haven't gotten yet, but I'm sure it'll come through, is, how long are people taking off, are patients taking off from work nowadays after weight loss surgery?
You're asking me?
Yeah, I think.
Okay, so
how long are people taking
really
off after surgery?
Heavily on what type of work you do, what your recovery period is like, and what type of surgery you had done. If, for instance, if you had a laparoscopic surgery, we're looking at typically 4 weeks, give or take, depending upon what type of work you do. If you are maybe a work from home and you work on your computer, you might be able to go back to work sooner than a person that's lifting heavy objects for your work. So it really depends. It's individualized.
Perfect. Karen, can you give and again, it's going to be a broad range because insurance covers quite varies, but one person asked, what is the cost of surgery?
Yes, most of our patients are going to be working with their health insurance. So it's important to know, first of all, if you have coverage, and we're going to make sure that we check that for you, but also we recommend that every patient check their own insurance because there are oftentimes going to be co-pays, some upfront costs. We currently do not have a package that you can self-pay for surgery. We are working on that. So our financial counselors will give you a pretty wide range of cost, which is high. Most people are not electing self-pay at this time. We recommend that if you do not have insurance that covers bariatric surgery, that you speak with your employer because oftentimes, especially if you work with them for a while, they will make a one-time exception to cover surgery for a employee rather than cover that benefit for everyone. But all government insurances cover bariatric surgery, so that's good news. And most of the larger employers, it's the smaller sort of self-employed policies that generally don't cover.
I'll take this next one. What do we do with the part of the stomach that we remove when we do a sleeve? The answer is we remove it and comes out of your body. For this next one, Karen, over the long term, what proportion of people regain a significant proportion of their weight?
Yeah, so it kind of depends on the studies that you're looking at, but most of the larger studies on bariatric surgery say that over time, somewhere in the range of 15 to 20% of patients will gain significant amounts of weight back over many, many years. So how we think about that is, 85% of people are keeping enough weight off to be a significant success. And it's not that the 15 to 20% of people are not losing any weight, but it's how you define that success. And sometimes we define success as far as, resolution of diabetes, hypertension, sleep apnea, and other problems. So the long-term outcomes for bariatric surgery are really very good in the range of, the 85 to 90% of people keeping off enough weight to have a significant health impact. As Bernadette mentioned, it is common a couple years down the line to gain a little bit of weight back, somewhere between 2 and 5%. And at that point, it really is all about the physical fitness and the exercise, right? Those patients that exercise in the highest level are going to be able to maintain the most weight loss.
I would add to the end of that, what Karen said about exercise. That actually is true no matter what type of weight loss therapy you look at. So every study that's looked at any type of weight loss ever, the most important thing about maintaining it as well as possible is some type of daily exercise, whether that's people that lost it with weight loss medications, weight loss surgery, the select few that only diet and exercise were enough, the people that kept it off over the long term, and we're talking long term more than 10 years, had some type of daily exercise. This next person, and I'll address it because I ran the calculation, said, I'm 6 foot tall and weigh 270 pounds. I'm told my BMI is not high enough. I have several medical conditions. Why do I keep being told I'm not a candidate? I'm not sure. At 6 foot and 270, your BMI is 36. Typically with other weight related health issues, you would likely be a candidate. That would be typical. So I would encourage you to submit your information to our intake, and we will check on your coverage. Maybe you have some very unusual coverage for insurance, but generally speaking, if you have BMI over 35, or depending on the insurance, potentially even lower than 35, plus 1 or 2 other health issues that are related to obesity, you should have coverage. In a similar vein, someone asked, what are the insurance requirements to be covered as a medical necessity and not cosmetic? No weight loss surgery is considered cosmetic. It's not a cosmetic treatment. It's a medical treatment. And so it's not considered cosmetic. Bernadette, what kind of is the typical time for when someone meets with us till when they go for surgery?
So that again depends on the insurance program, the coverages, the exclusions, how quickly that person follows up with the recommended testing and appointments. That's another thing. Those are, for a person that's going to have a sleeve, they often will need an EGD. You need that scheduled. You need certain labs done. So there's a lot of moving pieces to getting you to your surgery. Some people, it doesn't take very long at all. Like Medicare patients go pretty quickly. There's some other insurance plans that it can take a couple months or more.
Thanks. Let's see, this question, they said, where are the hunger receptors? Are they in the stomach or in the part that's removed? So the answer is, the short answer is we don't know. The long answer is it's incompletely understood, and I'll give you some more detail. So Hunger and the sensation of satiety or fullness or satisfaction with a meal is extremely complex. It has to do, yes, with the stomach itself, and there's little stretch receptors in the stomach that tell you your stomach is physically more full. It has to do with the body sensing that nutrients are moving through the small intestine and moving towards the end of the small intestine. It also has to do with brain signaling and how the brain is talking to the intestines. And it also has to do with our circulating hormones that are going in our muscle and in our fat and all those kinds of things. So very bottom line, it's a partially understood thing. Um, so, because if it was fully understood, it would be like almost anything else. If it was fully understood, we'd be much further along in our treatment of obesity and hopefully in the prevention of it. But what we do know and what we do understand is that the weight loss surgery works very well, and we understand to a great degree how it works, but not in all the ways. So long story short, it's partially understood, and there's many factors to it. And many of them are affected by weight loss surgery. I'll ask Bernadette, I'll ask you, did you experience any side effects from your weight loss operation?
So typical hospitalization is anywhere from 1 to 3 days. For me, I was in for about 2.5 days. I had nausea. It was I had some swelling from my anastomoses, and it took a little bit longer for that to resolve before I was able to go home. After that, I didn't really have many side effects, but that nausea, like your body will talk to you after surgery to help you stay on track. Nausea was kind of the biggest issue I had, but that resolved after maybe the first month or so.
Okay. To go over some other ones that you need to look out for the most common ones with gastric bypass are: number one, you cannot take NSAID medications. Number two, you can't smoke. Both of those are because those two things would give you an ulcer. The third one is, with all of them, you need to eat a moderate carb diet. And gastric bypass, to avoid something called dumping with duodenal switch, to avoid loose bowel function. And in sleeve gastrectomy, you won't get as many symptoms, but to help with the weight loss, since it's a little bit less powerful than the other two. So with all of them, it's recommended to be on a relatively low carb diet over the long term. Not a zero carb, but a relatively low one. Couple of questions about excess skin, always an important topic that people ask. Karen, can you talk about the necessity for skin removal surgery, or what proportion of people are even affected where they're considering that? Very common.
Yes.
Very common concern. I get it almost the beginning of every office visit I have.
Yeah, I'll start by saying the minority of people have any kind of plastic surgery after bariatric surgery. A little bit of it depends on your personal expectations. Most of the time, the loose skin can be handled just fine by a supportive undergarment, even if you have it. It's interesting, though. It depends a little bit on the age of the patient, the elasticity of their skin, and of course, how much they exercise, right? The exercise does help to develop that muscle under the skin. A lot of that extra tissue is metabolized and released from your body. But sometimes it fools you. The person that you think is definitely going to need a skin removal doesn't, and vice versa. All right. When it is needed, because it's causing some issues like maybe discomfort or rashes, is normally covered by medical insurance. Sometimes I saw a patient today. I didn't think she needed it all, but it was important to her that she had that skin removed, and I thought it would be cosmetic, and it was actually covered. So our plastic surgeons are pretty skilled in getting coverage for the excess abdominal skin, if that's something that's important to you and if it's needed, which is it is the minority of time for most patients.
And just to emphasize one of the questions, what's the best way to avoid it? Because there's some things out of your control, but the best way to avoid it is some kind of strength type of exercise to increase the muscle that is underneath your skin. After you've lost weight, if there's more muscle, you're less likely to have any kind of issue with skin. I don't think there's any new ones we haven't covered, other than some question that I didn't understand about independent caregivers. I'm not sure what that is. So I'll give some people a little more time to submit any more questions they have. In the meantime, I'll ask another quick one. Karen, a lot of people come in with a particular operation in mind. How in the end do we end up choosing which operation is the best one for a particular person? Because there's options, and people may not know what all the options are all the time.
Yeah, I think a lot of people do come in with a particular surgery in mind, and it's really a decision with you and your surgeon together. Our surgeons, including Dr. Gutnick, they're great at knowing all the pros and cons of each operation. As an example, if you suffer from severe chronic heartburn, chances are pretty good that they will not recommend a sleeve gastrectomy, because it's a very tight system and can cause the heartburn to get worse. If you are a person that really relies on lots of anti-inflammatories for a condition that's not going to get better with weight loss, so some kind of rheumatoid arthritis or something like that, they may not recommend a gastric bypass, because you can't take anti-inflammatories, but you can with the sleeve gastrectomy. So, there's a variety of reasons that one surgery might be better for you than the other. We also know that some patients will do better weight-wise with one surgery versus the other. But if there's something that you really want, particularly for a particular reason, maybe someone in your family had that operation, I think that most of the time the surgeons will consider very heavily the surgery that the patient, has researched and really wants as much as possible.
Yeah, I think unless for some reason it's really a bad idea for one of those medical reasons. We got another question. Is a pre-existing condition like diabetes or sleep apnea required to be accepted in the program? The answer is definitely not. The main requirements for most people end up being practical, which is, do I have insurance coverage for weight loss surgery? Most insurances, and you should check your own coverage because you can check your own coverage, but for most of them follow the guidelines of a BMI at the level of 40 or more, regardless of whether you have any other health issues or not, or a BMI between 35 and 40 plus a health condition that's related to obesity. Most commonly, high blood pressure, diabetes, sleep apnea, arthritis, heartburn, certain types of headaches, etc. So I would say, if you think you may be on the fence but are really interested in it, check your own insurance coverage, because some do have a lower BMI cutoff than that. And that's because many of the professional organizations that treat diabetes and other professional organizations that treat obesity and related problems like diabetes and high blood pressure have recommended lower cutoffs, and some of the insurance companies have started to go with that. So just if you think you're on the bubble or not really sure, you can always check your own coverage and see if you're one of the ones that does have a lower cutoff. And I think that's it for our questions. Well, thank you everybody on the panel for making the time. And particularly thank you, Bernadette, for sharing your personal story. It's very moving. And thank you everybody who attended today for taking the time to learn a little bit more about this. On our screen is the snapshot of the next steps. If you're interested in learning more or interested in learning more about this in your particular case, and we're happy to see you and answer those questions.